This committee, it's 2 p.m., 12 p.m., and this is May 8th, 2017, and we're on to 2A, be looking for approval of the agenda. You have a motion and support. Any comments or questions? Okay, hearing none, all those in favor, so going to say an aye. Not, same signal. All right, thank you very much. Okay, 3A, public comment. Public comment. We got all people reporting, no public comment. Okay, we'll move on from public comment to committee items. 4A is minutes for April 10th, 2017. Looking for motion and support on that. Okay, got motion and support. Comments, questions, any changes anybody wants to make to the minutes? Okay, hearing none. All those in favor, signal by saying aye. Not same signal. All right, thank you. We're on to AB. It'll be the medical examiner's semi-annual report. And for the doctor, we'll have Jill here presenting.
Good afternoon. Dr. Mano sends his regrets that he couldn't be here today to present to you the 2016 medical examiner report, but he's working in the emergency room at the moment. Does anybody have any questions with of the information that was provided? Great. So just a few points that I wanted to make today. As you can see from the report, it was one of our highest years ever as far as autopsies go. We completed 190, and we're on our way to exceeding that number, unfortunately, in 2017. County deaths overall, we're at, as of this morning, 683 deaths. Last year, we had 1712 in the year. We've also logged in about 166 cases that we reviewed so far. We did 362 in 2016. Our autopsies right now are at 93. We have, out of those, 17 are accidental, 18 are pending, 10 are suicides, and 23 are undeterminable. All 23 are actually, in the undeterminable manner, are all drug-related deaths. The undeterminable death levels are beginning to exceed our accidental deaths. If you look at the report, there is actually, that line is actually going above our accidentals. And that's actually pretty much it at the moment.
Mike? Oh, doctor.
Have you looked at or wondered in regards to the suicides, why the males every year back to 2007 always, almost 80% higher than the females, like especially last year, 14 and then 1. It's a consistent pattern across the scale.
Historically, it's always been, the male has always been higher, females always lower, significantly lower. It's in my experience, the whole time I've been with the medical examiner's office, it has always been that way. And I think it's consistent nationwide as well.
Any thoughts why?
Not really. Not for me. Dr. Mano might have an answer to that question, but I do not. Sorry.
Thank you.
Sorry.
Daniel?
How you doing today?
Great, thanks.
Good. I was just curious with the what classifies a death as undeterminable.
So an undeterminable manner, it doesn't fit into any of the other categories. So it could maybe with more investigation. So they're not going to say, especially with the drug-related deaths, we don't know whether they did it on purpose in order to kill themselves. Was it accidental? Was it a homicide that somebody gave it to them? If we don't have enough information to put it in one of the other categories, it goes under undeterminable. Sometimes we have some deaths, we don't at the moment, sometimes we have deaths that are actually undetermined cause as well, meaning we couldn't find the reason for the cause of death, and those would also go under that.
That kind of answered my question. So it's not the cause that's undeterminable, it's the manner.
Exactly.
If it was an accident or not.
Right.
Okay. Thank you.
Correct.
Bill?
Yes, thank you. Good morning, good afternoon. Do you have a breakout of the opiate overdose deaths?
Opiates, a breakout?
Yes, I mean.
I don't have I do have a report that we've been providing. We've been working with JNet to provide with them some information. The most recent information that I provided to them, actually I did bring a copy of that. I did do a breakdown. It doesn't have all opiates, but it does have, it is broken down to, actually, I think it's on the last page. The drug-related deaths, we had 52 in 2016. I have them broken down into heroin, cocaine, and fentanyl, into those numbers, how many different deaths had those drugs in their system. A lot of times, we're not seeing just opiates, but they're seeing a range of drugs in their system, not just opiates. So,
I mean-
but we are working with different agencies to provide the data, and from the data, they'll break out whatever information that they
So
want
if,
from
if
that.
a agent mixed in with an opiate like a fentanyl, that'd be a fentanyl-related death or an opiate-related death?
They're going to call it drug abuse.
Drug abuse? Okay, so do you keep records on drug abuse for the year?
For this year,
Yes.
we already have 23 drug abuse deaths.
Where were we last year? Is it your total?
I can't tell you where we were at this time, because our deaths, when our deaths come in, so if it's a January death, I may not see results from that until March or April. So it's usually a couple of months back. I always report on what I have that has been signed out. So out of the cases that I have signed out, 23 of them are drug-related.
So that's probably through March?
I can't
Oh.
necessarily say that, because some of those deaths that are on the pending list are probably still March cases.
Okay, thank you.
Because those won't be some of those March cases won't go out until the end of May. Usually, we tell people about 2 months standard to get back a cause of death. Sometimes it can be a little over and sometimes a little bit under.
Thank you.
Do we have sufficient storage?
Refrigerated storage,
Refrigerated
right?
storage.
Wouldn't it be?
The hospital morgue only holds 4 at a time. So we do have alternate things that we can do in the meantime. So, and that's, there's a lot of overlap with that. There's bodies coming into the morgue, there's bodies going out of the morgue at all times. So anyway, there's some overlap in there. We do have some funeral homes, a couple that have actually cold storage and can help us out in that regard. If for some reason things got really long-term, we might have to send it out of county, but that is what we have at this moment. And as far as numbers of unclaimed, it fluctuates. Have they been higher over the last several years? Yes. I don't have exact numbers on that at this point in time, but there's, I want to say, greater than 10, less than 20 last year.
And just out of curiosity, are those deaths mostly drug-related deaths, or is there a mix of?
No, and a lot of them aren't even medical examiner cases. A lot of those cases come from the hospital, and I have a lady that I work there at the hospital with when they have an unclaimed person that we need to take care of. We also get unclaimed for outside agencies. Sometimes they're coming in from care homes. The Allegiance Hospice Home has had actually a couple this year that we have had to take care of. So they come, sometimes they'll go to the funeral homes, then the families won't come back. So we'll deal with those, if we'll help the funeral homes deal with those. We also get them, obviously, from the hospital, that whether they're medical examiner's case or not. So we're always keeping track of who's in there, whether there are patients or not.
Okay. And speaking of funeral homes, I want to thank your office for dealing with our family in this last month and getting information, and sorry, I still can't talk about it.
Absolutely, that's what we're here for.
Mr. Chairman?
Jill, I want to first thank you for the assistance you provided to Deb Pemberton and the ongoing work your office is doing with Allegiance Healthcare and the mental health issues going on there, and deaths. I just wanted to thank you for that, and I really appreciate that. And your office has been very helpful in an analysis that really hasn't been done in the past. And that's going to be, going forward, I think it's going to be truly assistive to mental health as well as chemical dependency and other things on what's really going on here.
Right.
And I
there-
thank you for that.
Thank you. We are, on that note, we are trying to work with different agencies. We're trying to get to the point where we actually have one point of contact for those that kind of information, so that everybody's getting the same information, it's being disseminated the same way. There's a task force, and I do not know the name of it offhand, that they've just started off to keep track of numbers and things like that. So we're trying to provide information to them so that they can go forward with their numbers and provide it to all different organizations. Great, thank you.
Anything else? All right, Jill, thank you. You can tell the doc that you filled in excellently.
Thank you.
All right. Okay, we're on to Lifeways. Mary Beth? Your report there, I think you might have to change the first part of it.
Yeah, I do have an update, obviously.
Yes.
You all are pretty well aware, so good afternoon, Commissioners. I would like to, obviously, first and foremost, thank the County Commission for the support that you provided related to putting a mental health ballot issue out there. Greatly appreciated. It could not have happened, and I appreciate the support for this community, so thank you. I do also want to give a couple of updates related to where we are going to be heading. So the next step, obviously, is, as I shared with the County Commission about what we would utilize those dollars for, is going to be having planning meetings with local law enforcement, with the jail. We already actually started that process with the jail prior, but continuing that work so that we can come up with a mutual plan for meeting the needs, the unmet needs in our community. So I will be presenting that to the County Commission probably over the next couple of months as I pull that together. In your report, you'll see a couple of things. One is just an update related to, I shared with you that we were a recipient of a federal block grant for integrating primary health care within the community mental health, and we're doing that in partnership with the Center for Family Health, our local federally qualified health center. So you'll see in there some of the work that's being done around that and what the efforts of that integrated health project. It's going to be aimed at individuals who have a mental illness, but who also have a chronic comorbid condition or substance use disorder treatment issue. We will be focusing on several significant wellness components of that, and around weight management, obesity, smoking, and also as well as doing things related to nutrition and exercise to improve the overall health of the population. So we're really excited about it and excited about the partnership with the Center for Family Health. The next item in your packet talks about Mid-State Health Network. So as you know, when we regionalized with Mid-State Health Network, so we are a part of a 21-county region. There are 12 community mental healths. If you might recall, when we regionalized, one of the things that they had, and there was a value related to the system, was that they wanted to bring the bottom up and bring the top down, and to create over a 5-year period equity related to the funding. And so we are in year 2 related to that funding equity in the smoothing plan. And one of the things that they really wanted Lifeways and Saginaw, who are the 2 lowest funded, was to look at things to increase services. So we did a lot as a community mental health related to addressing increasing services. So we put into play a intensive crisis mobile service that I've talked about here before. We also put into play case management and psychiatric services being directly provided, as well as some transitional housing needs that were needed for the population that we serve that we didn't have the funds available prior to be able to do. One of the things that we've experienced is that our growth of those services and the cost of the services is going faster than what Mid-State had wanted us to be able to do. So where we are right now, over the course of this last year, one of the areas as an organization that we've really been looking at is our cost related to access. Myself realized that when prior staff that oversaw that area whenever there was a crisis, their response was we needed to hire more staff. And I kept saying, I don't think that this is necessarily, feels like we have a lot of FTEs in this department. So we did an analysis of our access area, and we actually reduced our staff from 34 to 17, which is about a $1.2 million savings annually. So we are doing things to bring our costs down for the smoothing plan. And the other thing that we will be doing is we'll be freezing any budgeted positions in the future, so, and analyzing any positions that come open. But I wanted you to be aware that we have done what was asked of us related to expanding services within our area. There's a lot of unknowns right now related to the community mental health, and that kind of leads me to the next item that I wanted to be able to talk about was related to Section 298, which now the language has been changed in the Senate to now call it Section 234. So the Senate has language in their budget that talks about privatizing the public mental health system. Both the House and the Senate have released their most recent versions, and both of them do include language for allowing for pilots in the state to privatize the public mental health system. And what does that mean when we talk about the local community mental health? So privatization of the public mental health system is really about where the funding of those dollars are going to go. So currently, the Medicaid dollars come down from the federal government through the state to the prepaid inpatient health plan. So that's mid-state that I talked about. So the dollars come there. And then from there, they disperse it out amongst the community mental health. And with our region, we've been creating equity and trying to create equalization related to how CMHs are funded. What this proposal is that the dollars would not go to a prepaid inpatient health plan, which there are 10 of them in the state, but those dollars would go to one health plan statewide. As I've talked about before, from a community mental health perspective, we're concerned about that. We're concerned about the impact that would have on the most vulnerable population in our communities. Currently, the system does not take those dollars when you have savings in Medicaid. They don't take those dollars and then put them into, our board members or put the dollars into shareholders. We actually are able to reinvest those dollars into services so that we can expand services. I was concerned about what that would mean because health plans are going to be wanting to see that there is a profit in the management of the $2 billion statewide. So the concern is about what would that mean to those that are the most vulnerable. We currently already have in the state of Michigan the responsibility of health plans to manage the mild to moderate. And they have not, in my opinion, done well with managing that. There's access challenges across the state related to people not being able to access mental health care through the health plans. So here the state wants to privatize and give the management of the most chronically mentally ill to the health plans. So I'm concerned about that, as obviously you can tell. So there is an opportunity for those who want to advocate on behalf of the system that we currently have to do that, because what's going to happen now is they both have different types of pilots being proposed, but now the budgets now will go to committee for recommendations moving forward. We will have to see, but again, there's a lot of unknowns about what's going to actually end up happening with the management of that. As far as what does that mean for the local community mental health, they're still going to have to contract with the community mental health to provide the specialty behavioral health services. I mean, the health plans don't even know or understand all of that, what we do. The obligation, what's written into the current budget legislation actually indicates that they do need to contract with community mental health. So we'll still be here. It's more about the concern about what impact is this going to have on local service delivery. So I just wanted to give you an update about that, and if you so are inclined and want to reach out to your local legislator advocating that the system stay public, feel free to do so. And that is it for my report.
Comments or question? Doctor?
I agree with you 100% because anytime a major health system gets in there, one, they're going to make a profit, so they're going to make the thing costly. So it's going to be more costly than what you have right now. Okay, and number two, getting access through that system, calling up and saying, oh, can I get an approval for this? Like in my profession, I have to get an MRI approved, I have to get a CT approved, I have to get surgery approved, and I jump through so many hoops, and it makes it more difficult, difficult access for my patients. So the same thing's going to happen, okay, with what they're doing now.
Right, and there's some examples. Iowa, actually, a state that's most recent, that went to the same model where they have gone and privatized the public system, and there's chaos occurring in the state related to this.
John?
Iowa. Yeah, Iowa. I think the Cranes did a nice report related to Iowa. I think it was Cranes.
Anyone else? Okay, I would just say what Mary Beth stated there. I have been talking with our legislators, both representatives and at the Senate level, for quite a while now. And if anybody thinks this is a bad idea, Doctor, might not be a bad idea. Because there are some concerns. I'm not sure the state knows what they're doing. And just a few years ago, they flipped everything upside down, added the Mid-State Health Network, 10 PIHPs, and now they're turning around and trying to change the thing all over again. So, anyway, any advocacy would be great. So, if there's anything else, Mary Beth, thank you.
Thank you very much.
Marcy?
Good afternoon. I'm Danielle Paquette with the Jackson County Department on Aging, giving the report this month for giving you information on our 2016 annual report. And I'm going to go ahead and just bring up my slide presentation. So each year when we're working through the annual report, we're definitely trying to see different changes, to see where we've gone up with numbers, look for any kind of decreases and trends that we need to be watchful of. And I just really wanted to point out some of the highlights in our 2016 annual report and looking at the various programs to see some of the impact that we've had in the community. The first program that I wanted to talk about was the Medicaid Medicare Assistance Program, and we did see an increase in the number of hours served by 26%, and that would be the number of hours served through our staff as well as our volunteers. We worked through the Continuous Process Improvement Program with our staff to look at ways, because what we see with that particular program is there's a lot of questions that come up regarding assistance with their health insurance, especially during that Medicare de-enrollment period, and a lot of our staff time gets designated to that program because people are looking for the best option that's going to impact them long-term as they look at their health insurance. So during that time period, we work with the volunteers that we have on staff, and we were able to bring in some extra support through the departmental secretary through that CPI analysis, and it really helped to impact the number of people that we were able to see, and it also helped to reduce the wait time that people had to receive a return call. Having that person up front that can help to direct them to the MAP coordinator if it should go there, direct them to Region 2 Agency on Aging if the call should get there. Sometimes we get people that are out of county, so we want to direct them to the appropriate resource and not have them get put to the MAP call line, where you can almost have, at one point in time, it was like a 2-week or 2-week time period to be able to get a return call, because the demand is just so high during that time period. So again, through that continuous process improvement, we were able to again increase the number of people that were served, reduce staff stress, and also serve our clients much better in the community. With the Meals on Wheels program, we definitely did see an increase in 16,850 meals served compared to the previous year. With that program, I wanted just to highlight some of the things that we do in the community. We do work with the community, the Consumers Energy Minority Advisory Council, and they help to do some fundraising during the period of like October, November to support the Meals on Wheels service. And one of the snapshots that you see shows myself with some of the volunteers. What we were able to do is to have some of those advisory members actually spend a day going out with the driver, kind of actually seeing the whole process that happens from beginning to end, providing that meal to the client. It really gives them the impact that that service has in the community. With that fundraising drive that they did in 2016, they raised over $3,000 towards the program. So again, it's a great service. It helps to educate the public. They're able to go back to the employees and share their experience. We get a lot of comments from them as far as how much the drivers know about the clients that they serve, right down to knowing what their pets' names are, where they want the meal placed when they bring it into their home. There's always instructions about how to enter a home. Some people want you to do a knock and enter. Some people want you to do a walk-in. Some people want to call ahead so that they have time to get to the door to unlock it, just for safety reasons. Whatever that person needs, the drivers learn a lot about them. They really become kind of like the face of the organization as they see those people on a regular basis. So again, that's one of the services that we definitely see a lot of growth in, and I think we'll continue to see that as people try to stay independent in their homes and live in the community. Another area that I noticed an increase was looking at our geriatric mental health area. In 2016, we did see like a 15% increase in clients. The area that saw the biggest growth would be the area of counseling services. That's where our counselors will go out to the home and offer that service to them right there. They don't have to worry about trying to get to the office, and a lot of those people have difficulty, and that's one reason they don't seek assistance for their grief and loss, their loss of independence, changes in living situation, family relationship problems that they're experiencing, and being able to offer that counseling helps to increase their quality of life. With that service, we also do like screenings for memory, depression. We do geriatric clinical assessment and referral services. So it's kind of like a gatekeeper program where we have individuals like Consumers Energy that may recognize an issue happening over the phone with an individual that's very tearful. They have a lot going on at the moment when they're calling. Maybe there's an energy shutoff notice, or they call because they're very confused about their billing. They don't understand what's happening. And we can be that person that can go out there and kind of see what's happening in that situation. Sometimes we're linking them to community resources, helping to contact family that maybe didn't realize certain things were happening in the home. So again, that program helps to provide a great impact in keeping people in their homes. With the senior activities, of course, we always do evaluation of how people are enjoying the things that we offer, things that they would like to see us try to bring to the senior centers. But what we found is a 95% reported a higher degree of health and life satisfaction as a result in their participation in senior center activities. And I really tried to capture that in the pictures that you see in that slide, from people doing crafts to companionship, socialization with friends, somebody that's painting, trying to take on a new talent, and improving their quality of life in that fashion. Pictures show fun, health, enjoyment, and again, we're just trying to capture as much as we can to bring people into the center to again impact their lives and improve them. So, yes. Mm-hmm. Yeah. I think there's a balance between when the drivers get to know that individual, so there's always that client that may need that little bit of extra time, so they'll spend that, but then somebody else just wants you to bring the meal in and, go. So I think you find that balance, and as you're delivering, you find those people that need that extra little bit of attention. Our drivers will come back to us if they do have concerns about somebody that they delivered to. So if somebody seemed a little bit more tearful or didn't engage them as they used to, like maybe the prior week, they'll come back and talk with one of the social workers just to see. I'm not sure if something's like going on, for example, with Miss Smith. So again, those are the things that they're on the lookout for, and we talk to them through the hiring process and training, so that they're like our eyes and our ears in that home. So sometimes we see them more than family.
Anyone else? Danielle, when you mentioned the mental health, you said memory. Is that similar to obviously a lot of the facilities? In fact, there's one being built right now here in Jackson County that deals specifically with memory care and more so for obviously dementia or Alzheimer's. Is the in-home services, is it similar to that type of thing as far as memory therapy or?
What they're doing is they're trying to conduct a screening to see if they're noticing indications that there's something happening there. So they go in and they do like 4 different tests, and they try to pick up signs of memory loss. It doesn't mean that that person has dementia. It just means that there's something happening there, and we get a signed release from that person that we can send that information to their doctor. Often at times, somebody might go see a physician or talk to their family and say, I'm getting a little bit more forgetful. And sometimes people may brush that off as just old age, but not really looking at that whole picture to say, I think something's going on here, because there's a lot of things that are treatable that should be looked at further if somebody's experiencing confusion.
All right, thank you.
Yeah.
Anyone else? Okay, excellent. Thank you,
All right, thank
Danielle.
you.
Yep. Quiet down there, please. Okay. Richard, Health Department. You ready?
Good afternoon, all. My report is, of course, in the packet and on board docs, and I just want to highlight a few things from that report for your information and attention. One of the first things that I included today was a customer satisfaction survey in my report, and talked about that. Overall, we do really well with the general customer satisfaction survey that we initiate at the Health Department. You can see the results are always in the high 90s to 100%, if you will, in terms of the building and the service/program and Health Department staff. So we're very proud of that. The one thing I thought I'd bring to your attention that is a little bit of a concern, and I guess it would actually be an increase on the no side, is whether people felt they got the needed assistance upon entering the building. And that is at almost a 10% rate for this October 2016, March 2017 timeframe. And as I indicated in my report, we really think it's kind of related to the initial entry into the Human Services building on the ground floor in the main entrance, which comes into the Health Department portion of the building. We've had some problems, some concerns for some time about our actual reception function. If you've come through that front door, we have a kind of a cubicle that's a little bit offset, and we're not getting the kind of interaction between the public and our receptionists that we want. We think that's part of the problem. It was also identified primarily by staff through the strategic planning survey that we did as well in the health department. So it's kind of popping up a couple different places. We would like to do something different than what we're currently doing with that cubicle, but it's going to take some resources to do that, and right now we don't have them available at our disposal. However, we are going to reposition that cubicle, do some changes to it, put more signage in place that really helps people to interact directly with the receptionists when they come in. So hopefully that will make a difference, and we'll see that show up in our next customer satisfaction survey. The next item that I wanted to revisit with you has to do with the immunization-related legislation. These two bills that I identified for you previously, probably last month, have not yet had a hearing through the Education Reform Committee, but we continue to be quite concerned about them. We do believe they will come to a hearing. And I did prepare just a one-pager, if you will, about what these two bills would do in terms of rescinding the entire rule that I've identified in the handout itself, Rule 325.175. So it does have a potentially large impact, if you will, on both school officials and local health officers, what we can do in terms of excluding people in the event that, and children in particular in schools, if a disease has been identified that is communicable, such as measles or mumps or rubella or pertussis, or whatever it happens to be. The rule change, if you will, by rescinding this would mean that I'd have really limited ability to exclude children who are not vaccinated and up to date on their vaccines, who could be susceptible in a school district unless an epidemic was declared. And the whole reason that we have the rules in place and we achieve high vaccination levels is to prevent an epidemic in the first place. So we don't think we really want to go in this direction of giving us less ability to control that within the school and other institutional environment. So I have had communication directly with Representative Alexander and Representative Roberts. Both are on the Education Reform Committee, and I would encourage you, if you have an opportunity, to talk with them as well and advocate to retain this rule in place in the state and the public health code. We have been continuing to work with local members of the community, and I would just tag a little bit onto Jill Glaire's report from this afternoon concerning the medical examiner's report for 2016. That information has been shared with us and came to the data collection committee that has now been formed up as part of the task force on heroin and prescription abuse. And we had a first meeting on, I believe it was April 14th, and had good progress. We had good participation from Henry Ford Allegiance Health as far as the ED data is concerned. We've had other data that were provided by Jackson Community Ambulance, and the medical examiner data was provided, and we're looking for a few more pieces of information. Our overall objective is to really increase our gathering of necessary data related to these deaths, overdoses, emergency room visits, arrests, etc., in an attempt to better drive our efforts to reduce the crisis. Yes, sir.
I really appreciate the direction you're going on this, and will you be sharing this with the board, either your meeting notes or the approved meeting notes from a previous month or something like that be sent to the standing committee?
Sure, you bet.
That would be appreciative. I mean, just so we can see it and review it and that type of stuff, because I have had a lot of questions. I know other commissioners have also, and that sharing that with us so we can share it with, disseminate the information would be really, really helpful.
Sure.
Thank you.
Will do. So we're continuing to meet, and we're optimistic that we're going to be able to have something prepared, I think, in more of a informative way than just statistics and numbers to share at the December Task Force Summit event. So we're looking forward to that. We've also had some conversation with a family medicine resident at Henry Ford Allegiance Health who's very interested in seeing what else we could do together to help reduce harm that's associated with this particular activity in the community. And so I don't have a lot of information to share right now, but there have been efforts in other communities and other states, if you will, that have serve similar purposes of what you refer to as harm reduction. So you may recall a couple of years ago, a rather significant HIV outbreak occurred in southeast Indiana, and that particular program that they put in place there was very much harm reduction related and had a significant impact on reducing further transmission in the community. Now, the Harm Reduction Center can also be used to help reduce prescription drug abuse and opioid use as well. It's not just about communicable disease transmission prevention. So we're going to look at that model. A few other updates that I have for you. As you probably are aware of, the Health Department routinely submits many grant applications, if you will. We submitted some to the United Way to support the Teen Pregnancy Prevention Initiative and also the Car Seat Safety Program. We were only funded on one of 4 grants that we submitted, so we're a little disappointed about that. But on the other hand, the United Way is really very much moving in a direction that we support as far as focusing on the social determinants of health. And as you're aware, the singular focus for United Way now is financial stability, and education and income and health surround that effort, if you will. So while we didn't get all the grants we were looking for, we're working very closely with Kristen Pluta, our county grant writer, to identify some other opportunities that we can use to keep both of those programs and services in place. We had, it's kind of late, kind of feels a little late in the year to be talking about an influenza B outbreak, but we did have one of those occur at a long-term care facility. It's usually not a large number of people, but still it could be anywhere from 2 to 10 people that we learn about that are potentially either testing positive or having symptoms of it. But we always provide guidance to the facilities, and we monitor these kinds of things as they're going on in the community, and this particular one did resolve within the month of April. As we have previously talked about in some of the other meetings, and particularly in conjunction with annual reports that we prepare for you on an annual basis, sexually transmitted infections continue to be one of our top, if you will, communicable disease rates in the community. You can see from my report that Dr. Katayan, one of our co-medical directors, will be doing an educational opportunity. It includes continuing medical education for physicians on Thursday, May 11th, and we're hoping we get a good turnout for that. We would really like to see one of our physician practices in the community begin to consider using what's referred to as EPT, which is expedited partner therapy, which can help reduce further transmission of STI in the community. So that's part of our project, is to work on that and putting it in place. I did include, for your information this month, a copy of the quarterly communicable disease report that we normally prepare and keep track of data, if you will. This is posted in the Health Department portion of the county website. You may or may not have known that, but we do this on a quarterly basis, and you can see for the time frame ending calendar year 2016 what our numbers were for the whole year. There's a lot of variability in communicable disease in the community. It kind of fluctuates a lot on a disease-specific basis, but we've been paying particular attention to the number of new HIV cases. You can see that particular line. We had a rather significant increase over the past few years, and we're continuing to maintain a focus on that. 2016 saw it come down, but we're still concerned about the number of cases that we've had here. The last item I had in my report was just a quick piece of information about the Vapor Intrusion Response Committee that has formed up in the state of Michigan. This is an effort involving MDHHS, the Department of Environmental Quality, and local health departments who are working to develop a protocol and procedural guideline, if you will, for doing vapor intrusion responses in local communities. We did have one of those here in Jackson County. It occurred at in the vicinity of a dry cleaning operation, and it can be a significant potential health hazard to people who live in homes where the product has been dumped, or it's spilled, or it somehow has otherwise gained access to the groundwater in the soil. It will move in a lateral direction and oftentimes can enter into basements, and then the vapors actually can be identified and tested for and assessed within a home environment. So that's part of what Don will be doing, is working with others in the state to develop this practice guidance template for doing those investigations. So that's pretty much everything I had in my report for you today, and I'm happy to answer any other questions that you might have.
Doctor?
In your list of the communicable diseases, I was just wondering, if you look at chronic hepatitis C, you've been up in the 500s and the 600s for the last 4 years, but now it's 141. What have you done, or what's happened that has decreased it by, 2/3?
Well, that's a very good question. I think one of the primary things that occurred here, and I appreciate you picking up on this, 2012, 13, 14, 15, you'll notice it was in the 500-600 range. This is actually a correction of the reporting process. 141 is actually the number of chronic hepatitis C cases identified in Jackson County residents. What happened in 2016 is they removed the Department of Correction cases from our number here in Jackson County. So-
Second question, under that legislation that you were talking
Yes.
about, if you read it, who is considered the local health officer? You, okay? So things about the schools and so on, and what kids can go and go is decided by you.
Yeah, I mean, obviously, we have staff within the health department who are very well trained and understand all the communicable disease control and prevention things that should occur. They're the ones who are monitoring cases that are reported to us. They're the ones who interface with the schools. They develop and share information with school staff and administrators, and that goes out to parents. But when we run into a situation where there should be exclusion occurring, and it might not be because of resistance within either the school or the parents or whatever it happens to be, those will get elevated to my level, and we may have to make a decision to actually exclude.
So I guess what I'm asking is that, when I see a wrestler comes into my office and he's got a MRSA infection of his elbow, okay, and he shouldn't go back to wrestling, okay, until he's cleared.
Right.
Okay, is that me who's supposed to do that, or is that you?
Well, if it's a reportable disease, it'll get reported to the health department, and I think that MRSA is. And it's a combination of us working with a healthcare provider to make sure that we're both on the same page and we're saying the same thing. Generally speaking, my staff would contact your office to discuss the case and to assure that we're saying the same thing to the wrestler and to the family and to the school. But yeah, it would be to exclude them until they're no longer infectious. But then there's a whole environmental cleaning protocol that usually goes along with that for the schools.
Okay.
Just using that as an example.
Yeah, because that's happened in the past, and I've written letters that they can't wrestle, or they can't play football, or things like that.
Right.
Put them on the appropriate medications, okay, and so on. But I've never contacted you, so I did
Okay.
not know if the primary care or the doctors out there know that they're supposed to contact you for that.
Yeah, it may be a little bit unclear about that. I'm kind of surprised that maybe you weren't contacted by somebody from the health department to discuss the case. And that's worth me following up on to find out if something fell through the cracks.
Okay,
So I appreciate you bringing that to my attention.
okay.
Yeah.
Thank you.
John?
I noticed that West Nile virus reported. I don't really see it too likely to increase, although we do have the mosquito capable of transmitting it locally from the mosquito to humans, if you will. Overall, we've not really seen much in the way of transmission that has occurred from year to year. It is present in corvids and other bird species, if you will, that can carry it, but for whatever reason, we're not getting the human mosquito contact from mosquitoes that are infected. So let's cross our fingers and hope that continues. Yep.
Anything else? Chairman?
They're not usually per se brought in, if you mean imported from another foreign country.
Somebody who moved here
Yeah,
in 15.
right. Usually, what we see with our active cases, if you will, is that oftentimes it'll occur potentially in someone who has been either living in a country that is more endemic for TB and has moved here to Michigan. It tends not to be amongst our normal population, right? I'm not for sure. Without looking back at it, I wouldn't be able to tell you. Mm-hmm. Okay. Yeah. Okay. I can get you further information on that particular case. Sure.
Anything else? Richard, one question. I see you got influenza, but you jump up to the flu-like disease, which it's an aggregate.
Mm-hmm.
From 2012 to 2016, it's jumped about 2,000. Why is that?
Flu-like disease is really kind of variable. Most of those numbers are coming to us and reported to us by the schools that have an obligation under the Public Health Code to report influenza-like illness to us. So it's pretty variable. There's no particular maybe explanation I can come up with as to why, looking at 2012 or 13, that it kind of suddenly doubled. But what I can tell you is that we did put in place, I believe in late 14 or 2015, an electronic reporting system for the school districts to make it a lot easier to report. So that may be partly why we saw a lot more reporting take place in those 2 years.
John?
I don't see it going down, but I don't see it going up either. All right. Yeah. Well, it's not always a really good match. We had a good match this particular flu season, but the flu-like disease numbers, if I can just refer to those very quickly, is really pretty broad reporting. It's not very specific at all to influenza. It could be everything from gastrointestinal to a respiratory problem, et cetera. And it's primarily based on what parents tell school district staff about why a child was ill and out. So it's not real specific or precise.
Anything else? All right, thank you, Richard.
Thank you.
Okay, we're down to 5A, claims. Okay. Move and support for claims, okay. All those in favor, signal by saying aye. Not, same signal. Thank you. We're down to 5B, other minutes, and that's just for your viewing pleasure. We have the Region 2 AAA, and we have DHHS and medical care facility minutes there. Down to C, June reporting, we have the Health Department, Department of Aging, DHHS, Medical Care Facility, and Veterans Affairs. And now we're back to 6A, public comment. Public comment, okay. Hearing none, committee members' comments. 7A, commissioners? Okay, hearing none, we are adjourned at the call of the chair, 12:53 p.m.